Hi. She is a 65-year-old lady who has this very peculiar cataract. On preliminary examination, it looked like a subluxated cataract, but on a detailed examination, it was obvious that it was more of an hypermature Morgagnonian cataract where the entire cortex is absorbed and there is an empty bag in this region, and there is this nucleus which is shifted to one position and got stuck there. So this was my interpretation at the slit lamp, and let's see how the surgery turns out. The surgery is being done under posterior subtenon anesthesia. Now let me pause for a moment and let me try to write down what are the challenges which I'm going to expect in this case. Number one, this is a long-standing hypermature cataract. So the integrity of the capsular bag and the zonules and their strength is going to be questionable. Whether I'll be able to perform rhexis with this weak capsule is a second question, and there's more likelihood that I may lose the bag and it might turn out to be an intracapsular extraction. So I've kept all my options open. If the rhexis is intact and the bag is reasonably strong enough, then I'm going to do phacoemulsification. If the bag is severely compromised and I'm unable to save it, then my plan is to extract the nucleus manually and then probably think of putting iris clip lens. Another concern for me is that the nucleus has got stuck in this particular position, so it is not mobile. Maybe it is got adherent to the anterior capsule and the posterior capsule, and I don't know how easy it is for me to dissect this nucleus out from the capsular fornix. The side ports are made, the anterior capsule is stained with trypan blue, the antechamber is pressurized with a dispersive OVD which is going to protect the corneal endothelium. And since I have kept the option of manual extraction of the nucleus and the iris clip lens, I'm consciously making a sclerocorneal incision. The incision is about 1.5 mm behind the limbus, and it goes all the way up to 1.5 mm into the cornea. Now typically I puncture the capsule with the forceps itself, but this being a weak bag, I'm consciously decided to use a pen 26 number needle just to puncture the capsule and raise a flap. And the moment I touch the capsule, this is the time when I really come to know the strength of the capsule and the zonules. As I'm puncturing, I notice that the bag is wobbly. Nevertheless, the anterior capsule is punctured and the flap is raised. The rhexis portion I'm going to show in slightly slower speed or in slow motion, as there are many things to observe. As the capsular flap is being held by the forceps and the tearing is begun, initially the tearing is easy, but after some time, at the distal portion, I'm seeing these capsular folds. And as the tearing is being done, at this area, I'm feeling that the tearing is not easy because the capsule is attached to the underlying nucleus. Nevertheless, I continue tearing, but this area, the capsular folds are too much and it looks like the capsule is not tearing and it's tearing in an uncontrolled manner. So this is the area with profound zonular weakness. I just leave the flap, make it flat, and then trying to re-grasp it again. With a combination of pulling and tearing, eventually the area of the weak zonules, the capsular rhexis could be extended, and then the rest of the capsule looks to be reasonably healthy. So I have a rhexis which is looking like a pear-shaped, and this quadrant is the area where there is a zonular weakness. But the rest of the quadrant, it looks alright. I'm trying to go in with my hydrodissection cannula, trying to pass it under the capsule of the nucleus. In some quadrant it does pass, but at this quadrant towards my left side, the capsule is firmly adherent to the nucleus. I am unable to pass it, and any forceful attempt is going to worsen the zonular dehiscence. So this was a tricky situation. I come back, and what do I do now? So I thought I could use viscoelastic to dissect out the anterior capsule from the underlying nucleus in a more controlled manner. I'm consciously using cohesive OVD, that is sodium hyaluronate. It's a space-forming agent. I'm going to inject it in the area where the capsule is not attached first, and then later in an area where it is a little bit attached. The cohesive OVD goes around the nucleus and it detaches it from its attachment to the capsule. So now the nucleus is free from its attachment to the anterior capsule, and this was a small trick which helped. The next job is to stabilize the bag. So plan is to introduce the CTR now itself because I don't want to postpone it. During the time of nucleus management, the bag with its loose zonules in this quadrant can be floppy and I can lose the bag. So timely intervention by introducing the CTR was a key step. The bag is already inflated with sodium hyaluronate. There is enough space so that the CTR can be safely inserted in the capsular bag. My preferred technique is always the bimanual method. Care is taken to ensure that the area of zonular weakness is adequately supported. So I'm just dialing the ring to the appropriate position. So this has ensured that the capsular bag is well supported by the capsule tension ring. But there's a thing to note here. You can see that the shape of the rhexis has changed now. Because initially the bag was in a collapsed state, the rhexis was in a different shape. The rhexis was looking a different way. But now with the bag being stretched by the CTR, the rhexis shape has changed and the margin on my left side has gone under the pupil now. But nevertheless, the good thing is the bag is very stable so that I can go ahead and perform the emulsification of the nucleus in a much more safer way. Now, because the bag is very empty and I am going to expect some amount of positive pressure because of a possibility of posterior fluid misdirection, even with the usage of CTR, I'm going to perform an anterior plane emulsification. The dispersive OVD is used to tamponade the area of zonular weakness and prevent the fluid from migrating into the posterior chamber, and HPMC is used above it. I'm going to use the burst mode, the chop mode, to engage the nucleus and then perform the chopping. Thankfully, the nucleus thickness is very less because it's a long-standing sclerotic cataract. So that eases my job. And it is also not very dense. So dividing it is not going to be a major challenge. The nucleus is rotated and the fragment is divided into two heminucleus. And the last heminucleus is now carefully under close observation is being divided. So now I have got 4 quadrants to deal with. Each of these quadrants is then being emulsified. So one concern is that the emulsification is all being done in the antechamber. So I will be concerned about the trauma to the endothelium. So I'm trying to be as slow and as controlled as possible and also as far away from the cornea as possible. But I still don't want to go anywhere near the capsular bag or inside it. Since the nucleus is not very hard and the nucleus was also not very big, the nucleus emulsification was relatively easy. There's hardly any cortex, so I want to put in the lens first. The bag is inflated well with OVD and the originally planned single piece lens is being implanted into the bag. The rhexis looks eccentric, but that is because of the zonular weakness. The shape has changed once the CTR has been put. Now the OVD is being removed both in front of the lens and behind the lens. Care is taken to decrease the infusion pressure. This helps us to reduce the floppiness of the bag also and any accidental of entry across the zonules into the burger space. Along with the OVD, there is some amount of remaining cortex which is aspirated out. There is a sense of positive pressure, but nevertheless most of the job is done now. Before closing up, I just want to confirm the absence of any transzonular vitreous prolapse by using diluted triamcinolone acetate, and thankfully there is none. The lens looks to be very well centered and stable. Time to close. The side port and the main incisions are hydrated, intracameral antibiotics are placed. That's it. So these are the next day post-op pictures. There's very minimal corneal edema, thankfully, and the patient was quite happy. So to summarize, this was a challenging case. There was multiple issues to deal with. Primarily the health of the anterior capsule and the capsular zonular apparatus. And we need to have a backup plan as well. In the worst case scenario, if the bag was lost, I was ready with an iris clip lens as well. But thankfully, the bag could be saved. The critical factor here was to get the rhexis right. Once we get the rhexis right, then we can always put in the CTR to stabilize the bag. And another important point was to dissect out the anticapsular and nuclear adhesions by using cohesive OVD. All these 3 factors helped us to prevent the loss of the capsular bag. So that was it. Thank you for watching and hope you found this helpful.